In human beings, it's important to note that cerebral blood flow is typically thought to approximate 50 milliliters of blood flow per 100 grams of brain tissue per minute. In a normal human being's brain, which is approximately 1,400 grams, this constitutes approximately 700 milliliters of blood flow per minute, or 15% of the overall cardiac output. That's quite a requirement and reflects the overall cerebral metabolic requirements of oxygen that the brain needs. That value is approximately 3.3 milliliters per 100 grams of brain tissue per minute, which results in approximately 20% of the total body oxygen consumption. Three main determinants of cerebral blood flow that we'll talk about are cerebral perfusion pressure, PaCO2, and PaO2. We'll talk about each in detail in minutes. These three determinants can be seen graphically represented here as pressure on the x-axis and cerebral blood flow on the y-axis. I'll break each of these variables down on their individual graph now. First is cerebral perfusion pressure. So cerebral perfusion pressure, again, is equal to MAP, mean arterial pressure, minus ICP, or the CVP, depending on which is greater. CPP is clearly affected by anything that changes the MAP. So acute blood loss, vasoactive medications, etc. Also, anything that affects the intracranial pressure, for example, intracerebral bleeds, tumors, an intracerebral abscess, these will also have the potential to alter the overall cerebral perfusion pressure. In normal brains, despite this changing environment, cerebral blood flow remains constant over a wide range of cerebral perfusion pressures. This is known as autoregulation, and can be seen in the graph as this plateau portion here. At the lower limits of autoregulation, cerebral blood vessels are maximally vasodilated, and it's important to note that any further decreases in cerebral perfusion pressure will be met with a corresponding decrease in cerebral blood flow. Conversely, at the upper limits of autoregulation, cerebral blood vessels are maximally constricted. Similarly, however, any further increases in cerebral perfusion pressure will be met with a corresponding increase in cerebral blood flow. It's also important to note that in patients who have chronic hypertension, many times we'll see a right shift of the autoregulation curve. This becomes very important in caring for these patients in that a cerebral perfusion pressure of 60 in a patient who is normotensive can be completely appropriate and adequate. However, it's easy to see with the right shift of the chronic hypertensive patient that cerebral perfusion pressure of 60 is dangerously close to approaching the territory where autoregulation will not be present. Next is PaCO2. The relationship between PaCO2 and cerebral blood flow is nearly linear between approximately 20 and 80 millimeters of mercury. Between these values, a 1 millimeter increase in PaCO2 typically results in an approximate 1 milliliter of blood flow per 100 grams of brain tissue per minute increase in cerebral blood flow. This constitutes approximately a 2% change for every 1 millimeter of mercury increase in PaCO2. As PaCO2 levels increase, cerebral blood vessels maximally vasodilate versus decreases in PaCO2 result in cerebral blood vessels vasoconstricting. This response of cerebral blood vessels to PaCO2 can be used to manage patients with elevated ICP. Hyperventilation reduces PaCO2 and causes vasoconstriction, thus reducing cerebral blood flow, cerebral blood volume, and ICP. However, if PaCO2 is reduced too much, the resulting increased vasoconstriction can reduce CBF to the point of causing or worsening cerebral ischemia. Also of note, areas of the brain that are injured, CO2 reactivity can be blunted or lost altogether. PaO2. PaO2 actually has little effect on cerebral blood flow as long as it is kept between normal physiologic ranges. However, in the event of a hypoxic event, key number being a PaO2 less than 50 millimeters of mercury, chemical mediators result in significant cerebral vasodilation and potentially severe increase in cerebral blood flow and potentially ICP. Maintaining normal PaO2 and avoiding hypoxia is important in all of our patients, clearly, but it's easy to see why it is extremely vital to avoid this situation in patients that are suspected of having an increased ICP.